guess I should go. Exactly. Open is when there's an outside opening to the environment. So anything that penetrates has now created an open wound. Most of the time, it's going to be something sharp. It could be something that hits so blunt and sharp that it pops things, but usually it's penetrating trauma that causes open wounds. And usually blunt trauma causes closed abdominal injury. So let's get right into it. We're going to talk about just this whole area right in there. And you can see it's a bad situation because we can't do anything about it. It's all in the core. There's no way to stop bleeding. There's nothing you can really do. Now they're making some, let's say, for penetrating traumas, gunshot wounds and knife wounds and things. They are making this syringe filled with radioactive swelling sponges. Have I shown you the XStat yet? The way it works is you take it. It is again like kind of like an applicator where you go in to the spot, you push it all the way in, and then you depress the plunger and you depress out like these lozenge shaped sponges. They look like Tums. And as they go inside, they have blood thickening agent on them. They have clotting, quick clot. They go and they swell up inside that gap that's been made by the injury. And as they swell up, they block all of the bleeding. And then the chemicals that are inside it stop the bleeding inside that spot. They're radioactive so that when you go to the hospital to get an x-ray and further on down the road, when you're doing the surgery, they can see each and every one of them and they don't get left inside the stomach. So it's pretty cool. They can use those usually for extremity injuries and things. And I believe you can use it for the abdominal cavity. That may not be the way it works now. I know you can't put it in the chest cavity because you just lose them inside there. But that thing has been used in the military for at least 10 years, maybe more. And they keep saying it's going to come out sometime now, but it hasn't shown up in anybody's protocols yet. So you realize anytime there's a new device, people are hesitant to use it because you would be, let's say, and think about it in the medical world, in the litigious world, the medical director is your person you work under their license. And if there's some new equipment that comes out, usually the medical directors don't want to be the first medical director to clear it for their county, because now if anything goes wrong, it shines poorly on him or her, and then they can lose their license from it. So it takes a lot of trials and some daring departments to go and use it. And then slowly but surely it gets folded out for everybody else. But as of right now, the XStat is not being used. So we're looking in this general area here. And remember, there's the peritoneal cavity, and then there's retroperitoneal. That's retroperitoneal. That means behind that whole cavity, we have things like the kidneys, the pancreas is also considered there. But we're going to be talking about this general area. So flank included, mostly front. When we get to GI, gastrointestinal, and GU, gastrourinary, we talk a little bit more retro, as well as with gyno and OBG. So management and recognition of blunt versus penetrating mechanisms of injury. We'll talk evisceration, impaled objects. We'll talk about hollow versus solid organ injury. And then external and internal genitalia injury, sexual assault briefly. This is our gut here. This is a much cooler image than the other one. Here's your liver with your gallbladder. They've kind of moved it out of the way. And this is how they used to do pictures in the old days. They would bring out cadavers and lay them out, and then there would be an etcher who would sit and go through that on a paper and then eventually transfer that onto a copper sheet. And then they would put acid on it. And as two acids interact and they don't react on the ink, it would dig holes into the paper, and then they could use that as a template to run off copies of like the gut, or the, you know, the pregnant woman, or, you know, any of the other parts of the body. It's kind of cool. Upper right, upper left, lower right, lower left. And you can see here what we're looking at, it goes all the way down to the pelvic floor, to the symphysis pubis. So you, when you're checking these people, it's not just boop, like you got to get down into this area. You don't have to be down here and doing that, but somewhere where you can press, and it's going to move the gut above and below on both sides. So, you know, picture that belly button, cut it in half. You're down and you're cross sectioning that in cross hatches. And it's 1, 2, 3, 4. So upper right quadrant, liver, gallbladder, duodenum. What's the duodenum? Anybody know what duodenum means? Yeah, exactly. Yeah, perfect. It's where it just kind of breaks off, and where the gallbladder is going to dump the gall, the bile into it, is at the duodenum. It's just a little specific portion of the gut. So if you're going to write and be a medical expert, you have to explain kind of every little individual unique spot, because it does a little bit different. You know, that's the spot where the stomach stops and the small intestine begins. Lower left quadrant, descending I missed some. Lower upper and some, bless you. So you'll see sometimes it's LUQ, or it'll be L or ULQ. So, and this means lower, left upper quadrant, stomach and spleen. Lower left quadrant, descending colon, left transverse colon. Transverse just means going across. Oh, it doesn't matter. And then lower right quadrant is our appendix, and don't forget the ovaries and things that are not necessarily GI, but they're in the same area. Okay, abdominal trauma can occur from blunt and penetrating, or both. Car accidents are a great example of that. If they go unrecognized and not repaired, repaired in surgery, significant cause of traumatic death occurs, and that's simply from not being aware, or really assessing the patient correctly. You know, this is for us, it's a little bit intimate, and it's a little bit intimidating to start doing this on patients or your classmates. But, you know, at some point, this is important for you to get over the shyness and start feeling healthy guts to know what they should feel like. And then if you don't feel it like that, if something looks off, that's when you should be able to, you know, detect it. And we're going to package and transport rapidly. Here are your solid organs. These, again, the big concern is that they are bathing the tissue in blood. It's a ton of blood for filtration. Like the kidneys, they filter through the pressure of the blood squirting through those little filters inside them. So if you sever a kidney, it just starts bleeding, like pouring arterial blood out into the environment. We've mentioned with the liver here, there's a little ligament that runs through it. And so if a patient decelerates quickly, like falling from a building or hitting in their car at side of a building or something, the liver keeps moving forward, but the ligament in the middle of it stays in the same place, and it just kind of slices the liver apart. Yep. That one doesn't really show it, but it's kind of in here. That one doesn't have a great picture of it. Let me see if the other one does. This one. So right here, it splits it right in that middle ligament there. And again, that was the artery that ran from your navel up to your heart when you were in utero. That was the way that blood went through to get to your body. And then as you change your circulation, as you start to breathe and that shuts off, that artery becomes, it just kind of flattens and becomes a little like scar-like ligament inside the belly. Okay. Solid organs don't bleed as much, but whatever they leak out is usually some kind of fecal matter. So not good. You don't want that erupting, breaking. Sometimes this can happen from just a hard smack. The pressure increases so much, it bursts those parts. Baseball bat can do it. Holding urine and then getting into an accident. A lot of people, when you got to pee and you're like 14 blocks from your house, what do you usually do? Yeah, zooming around. Well, the worst thing that can happen is you get hit or you get in a car accident and the steering wheel hits it right there. And, you know, that can happen. It's ruthless. So we're worried about that. Gallbladder can leak out. Any of this is going to cause fecal matter to escape. Anything here, there's your urine. Usually you don't hear too much about uterine trauma unless maybe the woman is pregnant during the time of the accident, because now it's swollen, it's much larger in comparison to the belly, and trauma is easier to that spot. Typically, kind of like the heart, the uterus is about the size of a female's fist when not obviously when not gestating a baby. Okay. And then the blood comes from the mesentery system. This is a good image of what the mesentery system looks like. This is the arterial branch of it, and it's coming down. The heart would be here. The aorta branches, arches, comes down, and this is now the descending aorta. This would be the thoracic area, if the thoracic aorta. Once it gets into the peritoneum, this is now your abdominal aorta. And you can see like this little lattice work of blood vessels that run through here, filling up the small intestine, the large intestine. And as that blood filters through, all through these parts is your food. So as it goes through, there's little villi, little finger projections that the food goes through, and it's interacting and taking nutrients from the villi. It's using, getting getting sugars and proteins and fats and starches. And then that food, then as the blood goes through, there's the venous portion of it that then brings it over to the liver for processing. Pretty gnarly. What would you say is going on there? We don't know. Who knows? Open or closed? Would you detect that? Looks like there's some kind of fluid inside there, possibly what, urine, possibly feces. It could just be a swelling and everything's kind of sagged over there. Bleeding, I don't know. It may be a little bit of blood, but he definitely looks perfused. Like there's enough blood in that patient that I would say it's not all entirely blood. Yeah. Both. Really, the arteries aren't to the front. So unless it's a deceleration kind of injury, those arteries and veins can tear, especially if they're swollen or backed up. But mostly it's the organs. And that's why if it's a solid organ, it's both. You're bleeding and there's tissue damage, there's organ damage. So that doesn't look too good, huh? So you can see this is what it looks like, busted open. You can see how by the way, there's a couple of images like this, so I'll warn you from here on out. But does this look life-threatening? It's serious. We have to deal with it. But it is, believe it or not, we're always concerned with either compromise to airway, breathing, or circulation. And if that's not causing profuse bleeding, we can't see because we can't get into the belly. But if that's not causing circulatory or breathing compromise, it's not life-threatening. There's a patient that I knew of that I told you got in a bar fight and his guts spilled out from a knife fight, and he passed out, woke up a few hours later and picked them all up and hailed a taxi to go to San Francisco General. So yes, serious. A lot of things can happen there. Not life, I would even say it's still code 3, but there's no circulatory compromise. The patient obviously lived, 30 minutes to an hour after the trauma. But the issue now will be, if it's not bleeding out, patient's not going to die from circulatory issues. It'll be infection. That open injury has now absorbed all the external debris and whatever's on the street in San Francisco. It's not good stuff. And so that has to go in and do that exploratory surgery, open them up wide, suck out everything. They flush, lavage, they'll flush the entire area out. Probably you'll be on antibiotics IV. They may put antibiotics in the gut. I'm not sure. I don't know how they manage it directly after you open them up and fix everything. But I would imagine they at least, sterilize the area, and they may have some way of keeping lasting sterilization in there without causing destruction of the gut bacteria and everything. And that's the other thing is, bless you, that if you have that problem, you're now probably going to have extensive GI issues for the rest of your life if you've done trauma to this area, especially, or septic issues. Yeah. So you can see, and it kind of bulges out when that occurs. And we're going to need to put an big occlusive dressing over that, moisten it, place over a big giant abdominal pad dressing with water on it. You moisten it up, stick it on, and then you have to put some kind of airtight piece over that. Don't stuff anything back in. Just get going with what you got. So motor vehicle crashes, motorcycle crashes, those are big because why? Well, you fly through the air and there's no crumple zones, there's no seat belts. Ejection is pretty likely in every case. Falls off of large buildings, blast injuries certainly, and pedestrian versus bicycle or pedestrian versus car, and any kind of rapid deceleration and compression. So if we have blood in the peritoneal cavity, there's usually pain to everything. The peritoneum, the nerves that are in there, if there's any inflammation, it causes diffuse abdominal pain all over the entire gut. There's also what's called referred pain, where pain to the back of the shoulder is likely. It's the same nerve root. So as people feel, you press here, they go, ow, ow, it hurts it radiates to the back. So not uncommon to have referred upper back pain to the same side. So let's take a look at some other stuff here. This is a closed injury, and you can see that there's bruising and everything else here. This would be previous, and this is after the blood is seeped to the outside. Remember that if there's a seatbelt worn, even though it's saving lives, it also does really significant blunt trauma in some cases. So you would recognize that, I would imagine, right? The thing with kids, usually if they're in a car seat in a 6-point harness, that's such a better support network for the patient. And hopefully they're small enough to fit, and they have shoulder side straps up in the groin straps. Those 5 and 6-point harnesses are really good at diffusing the stop, and not just focusing it in one place where the whole body bends over that one area. If that's the case and you have a kid in a car seat, you can take the entire car seat and put it on the gurney and transport them that way. Potentially, you can put a little piece of towel or something around the head and tape their neck and head in place. And that's good. Call it good. Don't spend much time with that. Just to make sure you get it. If there is a pediatric trauma center in the neighborhood, in your area, make sure pediatric patients go to that specialty center. Don't, even if it's mother, child. Mother goes to an adult trauma center, child goes to the pediatric trauma center. Most of the time it's the same thing, but in the East Bay, we have Children's and then we have Highland, and that might mean you're separating out those kids. It's going to be hard to deal with. It's a tough situation to handle. And you just have to be able to use your skills to convince the parent that their child is going to the right space. We make sure that we have them, entirely handled and accounted for, and then you have to, bring the parent off to somebody else. So that also means with additional resources, we're calling in a separate ambulance for either child or parent. So take a look at the airbag. I think that's faked, but that's not uncommon to see seatbelt across there and a belly brake. So we're looking for airbag deployment, seatbelts deployed out, starring on the windshields, crumple zone smash, dashboards over the top. How many people were in the cars, the roof damaged. We're trying to piece together this whole story by looking at the damage done to the car and the patient. Okay, we're getting into open injuries. This might get a little bit gruesome. These aren't bad right now. I wanted you to see this. What is that? Yeah, that's about what it looks like most of the time. Everybody always thinks there's going to be guts hanging out and everything. This is it. That's it. Right through. If you're not careful, you may miss that. And that's actually larger. I've seen them smaller in some cases than that. There's another one. You barely recognize it. Somebody thought the belly button was another gunshot wound, I think. But just for the discoloration and a little bit of, a little mark, you wouldn't think that's a gunshot wound unless you knew there was some kind of shooting that occurred. The damage depends on the speed of the object, whatever it happens to be, bullet, knife. Low velocity injuries usually do localized damage. The issue with low velocity is that either it's stuck inside and we have to figure out a way to package them with a stick or a broom or a rebar or a knife in them, especially if it goes through and comes out the other side. How do you deal with that? How do you C-spine a patient with that? The scoop stretcher, yeah. If that works, that's what you go with. There's really no, if it's this way, if it goes through from the upper right to the lower left, we're going to use a scoop. It's you have to figure out how to do it. In some cases, you may not even be able to use a scoop. So what you would do is have people hold that patient, maybe get them on the gurney or in some kind of conveyance that you could pick up as a whole and put in the hospital bed, and just have people holding C-spine, managing that patient all the way from accident scene to hospital. What about cutting that stuff off? What would you do if you had a piece of like a fence post through a patient? You don't know? What's that? You could do what? Cut off the edges? What would you use? Yeah, we got sawzalls. We have wire cutters, the big red guys that can cut through things. The issues with sawzalls, if you've used them before, is they catch and the whole thing starts shaking. What might be good is a circular saw with a saw blade. The ones that cut, it's less likely to bind up if you use it. That is a call for, this is why we have truck companies and rescue squads, by the way. They bring with them all of the construction equipment that a regular construction company would have, on top of extrication tools that you can, jacks and support structures that will secure the car in whatever position it's in. And now you can go in and work on them. So if you're ever interested, that actually, for my money, on a rescue squad, that's the best job in the fire department. Rescue squad is the best. You get all this specific training. You get to go and act as a truck company on fires, but you're basically a rescue operation team. So you go in and you're going directly to the patient. You're not bringing any water in. You're just basically navigating through the fire, getting to the patient directly and managing rescue. You get to do that, like I mentioned, all the construction stuff, the high angle rescue, the low angle rescue, rappelling, water rescue. It's just, if you like being active, most of the people that are in rescue squads are like, you know, they're into like extreme sports. They do Ironmans, triathlons, and they're just people that get out and live their lives. It's a really cool environment. So aside from the cool job, you get to hang with a lot of cool people. And, you know, there's always like dirt bike trips and hunting trips and fishing trips. And, you know, people do cool stuff in that department. Okay. So low velocity, boy, that was a side note, huh? Okay. So there's usually low velocity knives, rebar. I always mention rebar. I had a patient with rebar. They fell off of a 2 stories off a construction site and went right through them. So they hit the ground. Do you know what rebar is? The cement stuff? Yeah. Okay. So he fell through and went, and he was fine. It missed everything, but we got there and it's like this, and we had to get him out of there. Medium velocity injuries would be like small handgun and shotgun. Shotguns, they spray pellets. You know how the shotgun works, depending on the choke in your barrel. You can, when you shoot a shotgun, it just sprays out ball bearings, BBs, and then it splays out. It loses velocity pretty rapidly once you get about 20, 30 feet, which is why you need to be fairly close when you're hunting and shooting. It also is why oh well, doesn't matter. When you're skeet shooting, there's people out in the field like cleaning up all the time, and they're firing shotguns at you the whole time. But you just get hit, and you're like, damn it. It doesn't usually hurt you. Now, when you're going for high velocity things like hunting rifles, where the bullet, you know, goes, it's got that whole much bigger sized jacket behind it. That is just the grain, and that's going to speed up the round. And when you're dealing with that, we have to be concerned with, I'll show you, with the wake or the cavitation that occurs from it. So here's a good one that we could have, and it's not going all the way through, so we're in pretty good shape. Is it causing airway or breathing compromise? You know what that is? That is an intubation tube. So that patient is unconscious and does not have a gag reflex, and they are using this to give oxygen to the patient. It's a serious call. That is kind of, you know, pulling the skin up as it goes. The good thing about this, if there is a good thing, is that the knife is in position to stop the bleeding from the blood vessels that it's torn through. So yes, it's still bleeding, but the knife is occupying a space. And in a way, it's kind of pressing on all of the damaged tissue and not allowing that tissue to bleed. If you take the knife out, now you've created a big cavity and the blood can all bleed into that space. So keep the knife in place, keep the object in place, make it so you can package them easily enough. And then potentially you would put like some reinforced blankets, pillows, gauze, and just kind of tape that in so that it's not bouncing around. People see it. They're not going to hit it with their elbow. I mean, that does happen. And we keep it as isolated and immobilized as possible. And then when they get into the hospital, when they get to the OR, they slowly start to cut out the space, find the incisions. They'll do an x-ray to figure out how deep it goes. And they just basically kind of pull everything apart as they're going down, cauterizing wounds, finding the depth of it. You know, a couple hours surgery to get that out. You can imagine it's pretty rough. Also, if that knife isn't in place and they say, well, I got stabbed by a knife, we have no idea how big that knife was unless it's on scene. So even things as small as like an ice pick is about that long. It's only that deep. You know, the thing that you chop up ice from. In Goodfellas, they killed Maury with that, the back of the neck. All right. That ice pick's meant to break up ice, but it's a great tool for killing people because it's tiny, tiny, tiny and long. And you can go up in there and they'll move it around and cut stuff out. So try and find out the depth of whatever that blade was or whatever that object is that impaled them or stuck them so that you can get some idea. Of course, when in doubt, always just consider this to be the most life-threatening it could be. We're gonna consider that there's airway breathing or circulatory compromise and go code 3. These all warrant being code 3. So here is a high velocity round going through ballistic gel. I showed you this on something else earlier, but look at the cavitational wake it creates as it goes through. Look at that. So that is all body tissue tearing apart. This is going to be a relatively small hole compared to what comes out the other end. Usually what happens is all of this erupts through and that tissue kind of comes out the other side. Can be painful, visually shocking, or distracting. Don't push down on the abdomen. Only perform visual assessments when you're dealing with an evisceration. Any of these things, again, you could actually look at this and say, well, it's still pink, which means it's still perfusing. But what can also happen here is as it tears through, the abdominal muscles will tense up. And so that any herniation just means something comes out from where it normally is. As that herniates out, the muscle around it tenses up in irritation and it starts pinching that portion of the tissue. And that is what ends up killing that little bit hanging out. It's that the tissue between the peritoneum and the skin, the muscle and the fat and whatever else in the fascia, start to tense and they pinch off that piece. And if that piece isn't fixed, well, then that piece can die off. And then you have considerable GI issues later.
Would that be considered obstructive shock?
Well, it would be. But what it would be would typically, what if they're going to die of something from that, it would be probably septic shock. But you're right. It's squeezing off that piece. It's probably going to be septic shock. Okay, here's some hollow organs bleeding out, filling up the abdominal cavity. So here you can see, if you're looking at the small intestine, this is the mesentery system, and it's running through fascia and fat. And inside that are the arteries and the veins. It looks like those have burst in this one. They've been severed. So not even though there's the bleeding here, it's separated or opened up some of the small intestine as well. And as I mentioned, if any of this gets perforated, if any of it tears open, that's fecal material in the body. It's not good for you in any way, shape, or form. This is the extent the body goes through to completely isolate and wall off the external environment. We take it in, swallow it, and it goes through one tube in your body, and it gets digested and it gets out. The rest of your tissues cannot come into contact with that. In fact, it's almost like our tissues don't come into contact with it, because everywhere it goes through the tract is other gut bacteria, other different organisms that are in there. By the way, they say you have, like, every sixth cell in your body is yours. The rest of them are gut bacteria and other organisms living inside you. So of all the cells you have, you're only basically the only ones you can call your own. It's about a sixth of those. The rest of it is like billions and billions of bacteria inside your gut, digesting things, managing infection. It's pretty wild. So our concern here is going to be that it bleeds out bacteria and feces, and that kills the rest of your body. So just as I mentioned, the bacteria that's in your body that's beneficial, it's only beneficial if it stays in the small intestine. That can't get out and search around inside your gut outside of the small intestine. It's only good for us when it all stays in that contained little unit running through. And then here's another way, if you're thinking about how you could have a closed hollow organ rupture. You may not get hit with shrapnel. You may not have to have a penetrating injury to tear that open. The concussive blast from the primary explosion, you've seen that concussion go through. There's really cool videos in like the military where you see it almost crawl along the like a 2-mile path from the explosion to where the soldiers are. And you just see it go, it's like watching a cloud of dust roll across. They're far away from it there. If you were close, though, that concussive blast could explode your hollow organs, including lungs, but small intestine, bladder, not good. Another thing that can happen is when you fall, I mentioned paper bag. If any of this is filled up or you're holding your breath, falling causes the increase in pressure and can pop the lungs as well as the small intestines. Okay. Okay. And we don't want anything in the peritoneal cavity, including air, including waste, including bile. All of that's going to get you busted. Causes ischemia in the case that you were talking about. If that part of the tissue is hanging out and being pinched, you're causing gut ischemia. It's pinching off the blood flow to that space, and eventually also death if it doesn't get treated quickly. All right, let's take a break. Any questions so far?
ALS not very abdominal.
Meaning, what do you mean by that?
Abdominal is like the aorta basically.
No, we don't have anything that squeezes the aorta. So that's what you want, is those moments where they go, no big deal. Any questions about that? That makes it kind of makes sense, right? So maybe, yeah. Denzel.
Alexander's gonna find us.
You're going to get one ER and one fire department. That's the goal, is one ER, one FD.
Since it's already November 6th.
You got to get them done.
Even if they like can't go past like the.
You could go past the end of the semester. You got to get them done, though. Yeah.
Oh,
There will be some that go into December, probably past the date. But we got to get that paperwork. So you got to email it to me or something. We should have enough room if you get your stuff done. We need that. So make sure that I'll talk to Alexander, but we need to make sure everyone's accounted for going forward. If it means you only do 2 ambulance ride-alongs or you only do 2 hospital ride-alongs, so be it. But you need 24 hours, including the writing of the PCRs and everything all told, 24 hours of clinical experience in order to pass this class and be registered for National Registry. Okay, as we mentioned with bleeding solid organ issues, is that the bleeding in these cases is profuse, and you have to make sure that we don't bleed out. We don't allow these patients to bleed out. So that's our big concern, is that liver. There's a really good image of all of the ligamentums that go through there. A round ligament, all these different areas. This is the back side of the liver. This is if we're looking from the back forward, here's your big vena cava running through the gallbladder, and the fluid's basically going through these arteries here and flowing through the liver. The liver's then sending it through that to the vena cava to send out to the rest of the body. Pretty cool. Whoa. Go back. Okay, so upper right quadrant, slowly oozing blood into the peritoneal cavity, could look like that. Okay, that's what we're worried about. That's a liver bleed. Upper right quadrant, dog tag, patient right here. It's almost on the side of the lungs, right? So it's almost on the chest cavity. That may be a damaged thoracic cavity too, but that area right there is where we're the most concerned. And it won't just bleed in the one spot. Remember, blood is collecting and pooling down also according to the positioning of the patient. So we have to be aware of that. Spleen and pancreas, not necessarily bleeding out from the spleen, but there's also other juices in there that we have to be concerned with as they go through. So the bile, the issues with the insulin dumping, and this pancreas is hidden away back there to an extent where a lot of times issues with the pancreas are missed. They're misdiagnosed as epigastric stomach issues or splenic issues when it's in fact the pancreas. So a lot of times why pancreatic cancer is a death sentence is that it's usually found much later than other cancers because they run the gambit of all the other tests, and by the time they find it, it's in an advanced stage. Best thing you can do is avoid all of the sugars and all of the carbohydrates that you can. Okay, so side collisions oftentimes do it when you're side swiped or your vehicle versus pedestrian. You're the pedestrian getting hit on the side. That'll do it. Steering wheel trauma in some cases, fall from heights, landing laterally. Of course, motorcycle and bicycle and car and hitting or the hitting you sideways or the handlebars swinging around, knocking you on the side. This happens. I've never had, as far as I know, a ruptured diaphragm, but it can happen where the diaphragm tears away from where it articulates, where it attaches to the sides of the thorax and ruptures. And when this happens, the bowels go up into the diaphragm. So in addition to hearing lung sounds, you would hear the bowels moving the food through in the chest. Not a good situation. Also, because everything is going and invading the chest cavity, it's also displacing and crushing the lungs and the arteries that are in there. That's another kind of obstructive shock. That would be diaphragm rupture causing obstructive shock from your ability to inhale and fully inflate your lungs, as well as the collapse of the major vessels. Okay, now going around to the backside, we call it retroperitoneal. The kidneys, also very vascular. They bleed out quickly. Usually the first thing that we find, unless we're seeing bruising and swelling on the flank, on either flank, would be that you have blood in urine, kind of dark brown, or even just straight blood red inside it's like a rosy color when it mixes with the urine. Painful to the sides, excruciating, and then you're seeing that in the urine. So will we see that? Probably not, because I'm not hanging around to wait for a patient to urinate. Our best bet is to say, okay, do we see bruising? Are they complaining of flank pain? Let's just say the kidneys are ruptured and let's get the heck out of there. A big clue will be what's the mechanism of injury? How rapidly was it, how high was the energy transfer into the side of the patient? Look at this. Isn't that actually beautiful? Don't you think? I mean, the way that this stuff innervates and insinuates into the body, it's incredible. So you can see blood goes through here, and high pressure arterial blood goes up into these different fibers through here. As they roll through, these are all those little loops, and as it goes through, the osmotic pressure is spitting out like the nutrients and the waste products into all this tissue, and it's then collecting it and sending it back into the vena cava to go to the rest of the body to excrete it. Does that make sense? The higher the pressure is, the more the kidneys will take fluid off of the blood supply. And that extra fluid that they're pulling from the blood supply is your urine. So when your blood pressure is high, your kidneys start to pull more of the plasma out of the blood, because one way of dealing with high blood pressure is let's get rid of some of the blood volume. So the blood volume is pulled off of the plasma is pulled out of the blood volume, and then excreted into the ureters, and you pee that off. So one way of testing for like high blood pressure and things is, well, how often are you urinating? How often is the patient having to use the restroom? There's other things that'll do that, like diuretic hormone, another chemical that is triggered with alcohol. When you drink enough, it starts to trigger the release of diuretic hormone. Diuretic or diuresis is excreting urine. You're peeing it all off. So there are some drugs that people take when they have chronic high blood pressure to just pull the excessive plasma out of the blood directly off of the aorta to go immediately to be urinated out through the ureters. One of those is, they call them water pills if you ever go on a patient that has it. HCTZ is the drug that does that. And if you have issues with regulating blood pressure, that's one of the old tried and true ways of doing it. Here's another image of, would you imagine this patient has abdominal issues? It's not that pronounced. You know what I mean? You don't really see significant signs and symptoms that there's an injury here. Now you start to look a little bit closer. This is what your job is, to go, well, yeah, of course, you're seeing that. But would you pick that up if you're all freaked out and you're like, oh, okay, I'm gonna just check, and it almost could look like freckles or discoloration or something, you know? You need to be able to slow it down, look at these patients, look at their stomachs, palpate if there's pain, find the rigid areas, find the discoloration, even the slightest amount. And well, to us, we're going to treat it as if it's a major issue there. Not resulting damage may not be. Well, the injury may be apparent, but the resulting tissue damage may not be. And again, this whole issue with distracting injuries or painful injuries, this may not be painful yet because it has not swelled up to the point that it's pressing on the peritoneal cavity. This may be, and I've had patients that have lacerated livers or spleens or abdominal ruptures, but because it was from a high-speed vehicle collision, like their foot was broken. We have an open fracture of the tibia and fibula, and that is causing so much pain that they're not even complaining of the abdomen. The abdomen is going to kill them. This is just excruciating, but there's nothing that's going on aside from maybe a little bleeding that can be managed with a tourniquet that's going to kill them with the distracting injury. So we have to, yes, we'll treat the open fracture, put this is when being a lead EMT comes in really handy. The patient's going, it's killing me, fix it. You go, okay, I need to check. No, fix it. And you say, okay, Berlin, please, will you start working on that splint? Just splint the patient's leg, and I'm going to continue with my head to toe. And he's like, I'm screaming. We already have somebody on it. We got a pro. She's already working on it right now. I need you to focus on this, okay? We got it going on, though. Okay. And then you go through, take a deep breath, squeeze. Does that hurt anywhere? Listen. When I press down here, is that hurting? Yeah, ow. That hurts? And then you start realizing, it looks like there is a significant trauma to the chest or to the abdomen. And that only happens if, you can delegate off that treatment to somebody else in your team. They can manage the distracting injury, and then you can continue with the core kill zone stuff and make sure we don't have any apparent circulatory life-threatening issues to the abdomen or, anywhere else in the body. And it could just be a slow bleed. You never know. Don't do this if you're ever in a dare. Boom. Look again for, this would be pretty high, blunt, high velocity trauma. Consider all of the injuries when that hits that, ripple through the body. All the things that could have been injured as you go forward. But really, airway and breathing and making sure they have high flow oxygen if necessary, potentially giving positive pressure ventilation. Circulation, we're going to have to treat for the signs of shock, which means if we have a way of putting direct pressure on something, go for it. Again, this stuff is hard to do on an abdominal patient because there's no way to put blocking on there. Elliot, that thing was kind of cool. It was like a strap around there, but I don't know if it's going to get to the aorta. Oftentimes, what those were for, we had these things called masked pants, and you'd put on these pants and inflate them like fighter pilots used to have, like the inflatable pants, and it keeps the blood pressure up in the rest of the body. But for us, we're not using any of that. Our big treatment is rapid transport. Get out of there. Make sure you're bringing them to the appropriate trauma facility, and you're coming in having explained to the hospital staff on the radio report, we have abdominal trauma. You know, don't get stuck in saying, well, there's an open fracture of the tib fib and the patient's complaining of 10 out of 10 pain to the tib fib. We've got a splint on it. We're coming in code through high flow oxygen. And then you get off the radio and you go, oh, I forgot to mention the abdominal stuff. You got to contact that hospital. The abdominal problem is what they need to treat as soon as you get there. They're going to need abdominal surgery. They're going to need GI specialists there when you bring the patient in, because that is going to be what they rush off to manage. They're just going to sedate this patient and go and work on this. So that whole injury that's just freaking them out, they don't have to worry about it. They knock them out, shut them up, and then go deal with the life threat.
So it's okay to like hold them back.
You have to. You have to. I mean, it's not okay, but you have to. Like, you call them and go, I'm sorry, I forgot to mention this. And they're like, oh, really? Okay. And then you can just go and be like, oh, I'm fucking new. I'm sorry. And they're like, it's fine. You got it. You did what's right. No one's gonna get you busted for that. What's going to get you in trouble is if you don't call them back. There's going to be a lot of eating crow in the first couple of years of your job. It's okay. That's how it goes. Just go, I'm sorry. It was the dumbest thing I could have said. And they're like, it's okay. It's okay. It's okay. Don't let your ego get in your way of doing the job correctly and apologizing for when you do it wrong. There's plenty of dumb things that I did up until, I don't know, still 3 years into the job. You know what I mean? The thing that I got better at was admitting to it and fixing it quicker when I did goof up. And that stuff slowly becomes less and less and less. And then you get with a good crew who reminds you of things, and then they make jokes about it because you forgot it. And then you never forget it because they've, everyone's making a joke and you look at it and you go, right, it's that thing again. Okay, fixed it, and they giggle about it. That's what the job is all about. That's why people harass you. It's to cause you to remember to do stuff usually. Look for penetrating wounds. This is a big problem. But as long as, look, there's a little bit of blood pooling there, I'd be concerned because where is this thing going right through? Yeah, right through the liver. Bad news. Now, the problem is cutting this thing off and figuring out how to do it. But a bimetal blade may work for that. Of course, if you cut it with a saw, if this is metal and you cut it with a grinding blade, what happens to the metal? Yeah, so you have to like pour water onto the thing to get it cooled down. And now you're washing water down into the abdominal cavity. Hey, we got to get him to the hospital. At some point, it's like, that's the thing we can do that causes the least amount of additional casualties, of extra things. And that's it. We just got to cut it off and get them there, and then they can debride, they can clean it and everything else. But that was our best decision. And then you go back to the station and you talk about it, and somebody says something like, you had those big loppers. You could have just used the extrication tool with the little parrot beaks and just snipped it. And you're like, fuck, I didn't think of that. So then the next time you're on those calls, that becomes something else in your arsenal that you can use. We look for entrance and exit wounds. They're not always visible, but usually the exit wound is a little bit bigger than the entrance wound. In any case, they should both get occlusive, airtight dressings over them. Sterile gauze, if anything is protruding out, the evisceration should have some kind of wet and moist gauze, sterile on that, and then followed by using something like this transport tape. This is called a tegaderm. And inside there is a flexible adhesive saran wrap. So you would peel the backing off this and stick it over the hole. You want to pass that around? So you can kind of see those things. We use little ones that are tegaderms that we put over IV spots, and it just locks in the needle and the port and the catheter and the tubing. And you just place it over that. It's clear. You can see the spot you've what's the word I'm trying to think of? Well, you know, you can see the spot that you went into the vein, and then you tape everything securely after that.
Hey, Professor. This might be a dumb question, but
Hit me.
what's a good way to know what's the differences between entrance and exit wounds? Like, what's a good
Typically,
way?
yeah. Typically, the exit wound is going to be a little bit bigger, but there really is no way of knowing. So what they're going to want you to do, like, don't get stuck trying to figure out entry or exit. Just put a bandage on both of them, and make sure that when you get there, like there have been people that went to court and said, well, so the patient had an entrance wound to the lower right quadrant and an exit wound to the lower left quadrant or lower left back. And the lawyers would say, oh, are you a ballistics expert? No. Well, how do you know it was an entrance and an exit wound rather than a larger entrance wound and there were 2 bullets? And you're like, well, I really didn't. So it's not important, to be honest. It's not. Just treat them like 2 separate wounds. Do exactly what you would with one as the other, and get them to the hospital. Let them make the decisions on it. It doesn't change in our treatment whatsoever. Does that help?
Yes, thank you.
All right. So are you seeing these cool pictures too, Abe, by the way? Nice and pink, viscera.
Yeah, perfect.
Yeah, all that gooky stuff out there. Moist towel over that, and then put a tegaderm airtight wrap over that. Or you can take the package that the abdominal dressing comes in. It usually has a clear plastic wrapper. You take out the gauze, you moisten it, put the gauze over the top, then take the inside of the wrapper and place that over the gauze and tape it up in 4 spots. Keep it airtight that way. Yeah.
So, Tegagram,
Yeah.
that would be for the,
Just an entrance. It's any open wound. Any open wound gets an airtight occlusive dressing like a tegaderm over the top. Now, we practiced the other day using duct tape. You can use saran wrap. The only issues with saran wrap, it might be a little too weak. It may not hold there. Same thing with the tegaderm. You might want to double it up or something and put it over the top, just so the stuff doesn't pop through with the pressure changes as you're moving them around. That probably is going to be fine for an abdominal issue. I don't know. Maybe I'd have a concern if it were going on a sucking chest wound, because they're really, really thin.
and then with like the whole, that would just be like gauze around it.
So abdominal injury you're talking about?
But yeah, abdominal with the acid hole, that would.
We'll practice with this. You're going to get a big piece of gauze that folds out. It's that cloth white stuff. Moisten it down with water, not salt water or saline. Place it over that area. Dry the sides around there really well. Wipe it, wipe it, wipe it. And then put on a plastic piece of something, either a plastic bandage or the tegaderm, and place it over everything and stick it to all 4 sides. Make it airtight. That's what we call an occlusive dressing. So the reason is, when you take that off, you don't want the stuff to stick to the bandages. It may stick to that tegaderm. If you pull it out, it starts to tear it away. If you put dry gauze on that, it's going to also stick to the gauze, so that when you take it off, it starts to tug all of that viscera, meaning intestines, out of the wound. So you just throw a little bit of water, sterile water that we carry, moisten the dressing and place it over the top. It's not dripping, but you wet it down, squeeze it out, put it over the area, put in occlusive dressing over all of that. And that way, if it's not dripping, you'll be able to seal it, adhere it to all four sides. So again, same rules apply. It's going to be sticky. It's going to be potentially bloody. It's going to be, hairy. You do your best. Wipe that area super clean and dry with other gauze, and then put everything on and tape it in place. So here it is, kind of going through it here. So there is your evisceration. This is a sterile, wet piece of abdominal gauze at the upper right quadrant. Lower left is now placing the occlusive plastic sheet over the moistened gauze and the evisceration. And then in image D, taping it across all four sides to keep it airtight. They're going to get to the hospital, and within about 10 minutes, that thing's gone. It's coming off. So just remember, it's more or less for packaging your patient, keeping this from touching the sides of the gurney or, dangling out and hitting the spider straps or whatever you have. That's going over the top. What would you put spider straps on that spot, by the way? No, just scoot them down or up or something out of the way. And you get going to the hospital. And then they're going to get there and they're going to slowly start taking that off. But it'll probably be all the way off in about 10 minutes as soon as you get to the hospital. As they're cutting clothes and talking to the patient and checking vitals, someone is working to get that removed, assuring that there's no circulation issues, they're not bleeding out, and they'll take that off and then make a decision on what to do next. Yep.
What's the average length of time at a hospital after birth?
Half hour. Writing the PCR is usually what you take the time doing. So you drop them off, it takes about 2 or 3 minutes, and then you go and you write your PCR, and then you leave that there and you leave. That's what the transporting agency does. So in San Jose, we were not a transporting agency. We were the ones that showed up first, stabilized the patient, began treatment, and then we'd hand the patient off to a transporting ambulance company. Then they would take the patient and they would drop them off, give the patient report, write a PCR, hand that in, and then go back into service. So it depends on the county. If anywhere around here, your fire department agency is going to be transporting as well. It was just something in larger cities. Usually there's a private ambulance company that has the contract. So you end up handing them off. If the patient is really bad, I would just ride along with them to the hospital. Just be an extra hand, maintain patient care. I'd be the lead EMT or lead paramedic, and I bring the patient to the hospital and they just assist me along the way. Sometimes I would hand off patient care to them. If it were a medic that I wasn't confident in, or I knew they weren't going to see it the way I saw it, I would maintain care over the patient so that I'm the lead paramedic when I get there. And that can be tricky, but sometimes necessary. All right, let's get into the genitourinary system. This gets a little bit ruthless. And I left out some of the pictures. I would really hesitate going and looking at trauma of the genitals if I were you. There's some really tough stuff to look at. Hopefully you don't run into too many, but the big ones are like sexual abuse and everything too, along with it. It's just fucking barbaric. So some people are monsters, just to be honest. In any case, we're looking at not just the urinary system, but also the reproductive system and all of this stuff. You can imagine when you damage these areas, it's pretty traumatic. Aside from the emotional trauma that goes along with it, a lot of this stuff bleeds a lot. We've mentioned, the fallopian tubes and the uterus itself, although it's hollow, does have a lot of vasculature in there. So all of this stuff, especially this is a spongy, fills with blood, not always, but the penis is basically a giant sponge that can fill with blood when needed. And so if there's any bleeding going on, there are large arteries that are attached here. So that can bleed out pretty easily. You also have to worry about waste, urine mixing into the different organs as well, which can be, you know, cause another infection and just a whole bunch of issues down the line. This is the external stuff, also vulva. We consider that external, female genitalia, labia, clitoris. That it would be what, you know, we can basically work on. There's not, we're not inserting anything on any of these calls. If we have open wounds, we're not packing them with anything. If we have bleeding from the vagina, you're not packing it with gauze. You just let it, you basically put a large gauze in front of it and try and collect what comes out. The other concern is that if this is sexual assault, you don't want to be stopping that up. All of that fluid that's coming out is now evidence. So do your best to, as we're talking about this, you know, try and assuage the patient from taking a shower or cleaning up. There will be a sexual assault response team at the hospital to manage this stuff, fortunately. And a lot of the crew that does it are, you know, they're trained nurses and doctors. Some of them are actually sexual abuse victims. So they can kind of identify immediately with the patient, get on a rapport, and then they expediently collect samples and then decon the patient as humanely as possible. But unless it's external, we really have very little control over the stoppage of blood. So ovaries and these fallopian tubes and all of this can bleed pretty extensively, especially if it's a sexual assault, and especially if it's a kid. Quickly, let's get into this, like hitting the kidneys. You can see why this would be a concern, smashing in there. Yeah, flank pain, flank injury. God, he was a monster, wasn't he? He was amazing. So those are usually not allowed, flank smacks. You know, you're not supposed to be doing that. But if, again, you notice that there's blood in the urine coming out, it doesn't have to be a boxer either. It can be the, you know, a woman who's sideswiped or hit on the side, or a man who's hit on the side. They usually don't happen in isolation. There's usually not just one punch to there. It's usually a side swipe trauma that damages the flank, the chest cavity, maybe the face, and the side of the head, the temporal area or the parietal area. Suspect if there's any abrasion to the flank. Flank, do you know what flank is? Yeah, that's where flank steak comes from, actually. So not surprisingly. Laceration, contusions, penetrating wounds to that area. Or, you know, above or below it, or a little bit anterior or posterior. Fractures to the lower ribs. Oftentimes what can happen is the ribs fracture and lacerate the kidney. Okay. Lower thoracic or upper lumbar vertebrae. Hematoma, certainly, and hematuria, or bleeding in the urine. Hematuria is blood in urine. Here you can see, I think this is a ruptured bladder. These are people rushing with a full bladder that get into accidents, and that bladder bursts and fills the entire cavity with urine. Now, they say urine is more or less sterile, unless you have a kidney infection or bladder infection, but it's waste product, and it's going to be concerning, and it's going to be very painful and an extensive treatment to fix it. Yeah, deceleration can do it, but also pregnant women have the belly is protruding so much that the bladder also is being pressed on. That's why, I mean, urinating is usually like every half hour when you're in your third trimester. There's just zero room in there for the bladder to fill up. And so if you have a pregnant woman that's involved in an accident, a fall or a car accident, that's a much easier way to burst either the bladder or the uterus. So here you see a part of the symphysis pure, the ischial tuberosity. That's called the ischium, your butt bone. That's the spot that you sit down on. When you feel that little sits bone or butt bone, that is your this is called a tuberosity because it makes a tubular shape in there. If those fracture, that can puncture the bladder. This is your symphysis pubis right in the middle. That's another piece of cartilage that allows for a little bit of movement. So we have a little shock absorption. You can do a little bit of locomotion with it. This really, when a woman is in her third trimester, with the advent of elastin, which is a hormone that's created, all of your connective tissues become much looser and limber. And the goal is for the elastin to activate on the symphysis pubis and allow it to flex and bow and move around so that the baby can get out much easier. The issue is when elastin is created, it's non-specific. So it works on all the connective tissue. So the knees, the ankles, all of this stuff is loose and limber. And I even have to my sister, you're walking down the stairs, do what you normally do, but there's no stabilization. And so the leg buckles, person falls onto the ground. Now you have a trauma with a pregnant woman. So there are, believe it or not, a lot of calls in third trimesters for women. They're like, I don't know. I was walking down the street and my whole leg went out and I fell on the ground. And that's usually a product of that additional elastin hormone that's meant to beneficially allow for more stretching and movement of the pelvis for childbirth, but it's also causing all the other tissues to become limber and, double jointed and unsupportive. Okay. This is about the most humane picture of a penile injury. Great pain and of great concern, rarely life-threatening, but it can bleed. And then treat it in order of priority for, make sure you're handling the bleeds everywhere else, circulatory compromise everywhere else, and handle that. That's actually pretty humane. Another thing that can happen is the scrotum tears open and the testicles kind of hang out. So in that case, you have to collect all of this stuff. Okay, I mean, you have to, this is the goal here, and they're going to thank you for it. But what can happen sometimes is in this accident, the scrotum opens up, the testicles fall out, and then as they're getting up and moving, it tears off of the epididymis, and you lose the testicles. So make sure you're collecting all this stuff, bring them to the hospital. You can imagine somebody with an injury to the genitals. It's just extensively traumatizing. All right. Real quick image of vaginal injury. This is, again, something that this is about the most humane picture I could see. There's a lot of bad stuff usually regarding children and sexual assault, and I just don't look it up. It's rough. So that can be infection, it can be bleeding, it can be just scarring and everything that happens later in life as it heals. And aside from the pain and the emotional torment, the scarring and the way that it heals may completely may not allow the female to get pregnant later in life. So depending on how bad it is, the scarring can cause an environment where the egg can no longer latch on and grow, because that scar tissue doesn't have a lot of vasculature. So from childhood sexual assault or trauma, it could cause a woman to be barren in her life. Again, it's something that we have to be able to manage as best we can. Bring in the experts as soon as you can. That's it. Questions? Sorry to end on such a high note. Holy God. But really, it's for the most part, these things, as long as there's no airway, breathing, or circulation issues, our next biggest concern would be infection and bringing them to the right trauma center for appropriate care and treatment. All right, let's take another little break. And we'll come back and we'll start talking about the PCRs and everything. Hello. Hey, Ron, how are you?